Greetings to one and all. Hope you all are keeping safe in these unprecedented times. This is Dr. Yash Kripalani bringing you this short presentation on the review of the current guidelines on diagnosis and management of COVID-19 and what have we learned so far during this pandemic. I work as a resident medical officer in the intensive care unit in one of the largest cities of India, that is Mumbai. And India has seen the largest surge of coronavirus daily cases in especially the later half of the 2020. Hence, a review of the current strategy in order to tackle COVID-19 is necessary, as a definitive vaccine is far from being available to the general public. Hence, we need to devise a strong diagnostic and management protocol in order to reduce hospital admission, thus preventing collapse of the healthcare system, ultimately saving more lives. COVID-19 is caused by an organism known as coronavirus or SARS-CoV-2, that is Severe Acute Respiratory Syndrome Coronavirus 2. It began spreading in Wuhan, China as the epicenter of its outbreak in December 2019. It soon spread across the globe to many countries like the United States, India, the European countries, ultimately being declared as a pandemic by the WHO, that is the World Health Organization. Number of daily cases surged exponentially, leading to an increase in number of patients requiring hospital admission. This forced the governing bodies of many countries to impose a nationwide lockdown in order to curb the spread of the virus, thus preventing overwhelming of the healthcare system. This led to a major economic collapse worldwide, causing mass unemployment. Despite all measures, hospital admissions continued to increase, leading to a shortage of beds available in the ICUs and equipments, such as ventilators. It posed a huge threat to life as well as livelihood to people across the world. Infected patients generally present with mild symptoms such as fever, cough, fatigue, body ache, headache in their early stages of infection, resembling a flu-like illness. Few cases may present with loss of taste and smell as well as abdominal pain with diarrhea. The incubation period of the virus is about 10 to 14 days, during which an infected individual would remain asymptomatic. Thus, this particular individual spreads the virus without having an insight of being an infected person. On physical examination, the patient would appear weak and fatigued, showing signs and symptoms of tachycardia, tachypnea, which is also known as racing heart, as well as shortness of breath. On auscultation, a clinician may find crepitations or crackles bilaterally on both lung fields. Severe cases may present with acute respiratory distress syndrome, showing a drastic fall in oxygen saturation while appearing normal. This person would appear normal even though his oxygen saturation is dropped to about 85%. This is known as happy hypoxia. It's very commonly seen in COVID-19 patients. The virus gains access via the enzyme ACE2. This enzyme is present in the type 2 alveolar cells. Let's discuss a few details on the morphology of the virus. The virus was isolated and examined under an electronic microscope, and it appears to be about 70 to 90 nanometers in diameter. It consists of spike glycoprotein projections on the exterior, giving it a crown-like appearance, hence being named as coronavirus. The virus membrane, glycoprotein, and envelope are embedded in the host membrane, derived lipid bilayer. This covers the nucleocapsid comprising of viral RNA to resemble a beads on a string-like appearance. Prevention. Let's speak on prevention now. By now, we have a brief knowledge about the nature of the virus, especially the mode of transmission. It is transmitted when an infected patient coughs or sneezes, releasing body fluids such as saliva, which comes into contact with a healthy individual, thus infecting him or her. The gold standard measure in order to delay the spread involves washing hands up to 1 minute, covering the mouth, nose, with a face mask and avoid touching the face, especially the eyes, with unwashed hands, and maintaining distance from people from about 1 to 2 meters. Healthcare professionals treating COVID-19 patients required to don a special kit known as personal protective equipment, consisting of N95 masks, gowns, gloves, head caps, eye protective gear, etc. Donning PPE kits for a long period of time is proven to be uncomfortable, leading to many complications, making it more difficult to provide adequate healthcare services. Diagnosis of COVID-19. As we do not have a definitive cure and vaccine is far from being available, early detection of signs and symptoms and diagnosis of the infection plays a key role in delaying the spread of the virus amongst the people in the community. Laboratory diagnosis is done by detection of viral RNA. This is achieved by nucleic acid amplification test. A very common example we all know is real-time reverse transcriptase polymerase chain reaction, in short RT-PCR. RT-PCR testing requires samples to be collected by a swab from the oropharynx or the nasal cavity. Apart from this, we have radiographic imaging, which can also aid in the diagnosis of the disease. A very commonly used radiographic technique for detection of COVID-19 is high-resolution computer tomography of the chest, or in short HRCT scan of the chest. Chest X-ray can also be useful, but providing a definitive diagnosis of COVID-19 through a chest X-ray is not possible. Routine laboratory blood tests also show some derangement which is quite peculiar to COVID-19. This will be discussed in detail. Diagnosis of COVID-19 faces a tremendous challenge as this virus is relatively new to mankind. An ever-growing human population and a lack or a serious shortage in the availability of good quality testing kits makes it all the more difficult to obtain a proper diagnosis. RT-PCR testing kits requires an extensive amount of time of about 24 to 48 hours to obtain a result. A negative point to the RT-PCR testing is low sensitivity and specificity towards COVID-19, leading to a huge number of test results to be either false negative or false positive, even though patients suffer from the exact same signs and symptoms of the infection. It is highly advisable to conduct a radiographic scan such as an HRCT in order to obtain a proper diagnosis for every suspected patient of being infected by COVID-19. This not only gives us the benefit to diagnose, but also plays an important role in determining the prognosis of the patient. This gives us a clear idea of the amount of lung involvement in a particular patient and helps us to formulate a better treatment plan. CORAD scoring of the HRCT scan is the standardized protocol that is followed in every hospital to assess the pulmonary involvement of suspected patients. This slide gives us a detailed overview of the CORAD scoring technique. CORADS 1, which suggests a normal HRCT scan with no signs of infection. CORADS 2, which suggests abnormalities seen are consistent with infections other than COVID-19. These patients are less likely to be suffering from COVID-19. CORADS 3 suggests that it is unclear or the radiologist reporting it is unable to determine if that particular patient is suffering from COVID-19 or not. CORADS 4 suggests that the abnormalities present show signs of COVID-19 infection or the patient is highly suspicious of being infected by COVID-19. CORADS 5 suggests that the abnormalities present are typically seen in patients suffering from COVID-19. There is a very high chance that this patient will show a positive result on the RT-PCR test. CORADS 6 is the confirmation that this patient is infected by COVID-19, which has been also proved on the RT-PCR test, as well as shows typical ground glass appearance on the HRCT scan. Let's discuss some of the CT chest findings. An axial cut on the CT scan without a contrast is generally preferred, that is a plain HRCT scan. Typical findings that suggest that this patient is suffering from COVID-19 are bilateral peripheral ground glass opacities with or without consolidation. Septal thickening is also commonly seen. The CT image that you see on the slide shows ground glass opacities on both lung field on the peripheral region. With poor prognosis have extensive pulmonary involvement. Such patients develop fibrosis as the disease progresses. This is very commonly seen along with septal thickening in such patients suffering from terminal illness. A repeat scan of the chest is required to confirm prognosis of the patient suffering from COVID-19. An example of a chest X-ray of a patient suffering from COVID-19 is shown in this slide. It shows bilateral patchy consolidation in the peripheral lower lobes. Routine laboratory blood investigations are performed for every patient admitted to the hospital, regardless of the diagnosis of COVID-19. A very common and routinely performed complete blood count shows decreased lymphocyte count with a low lymphocyte ratio. Research performed on various patients suggests that at least 45 to 50% patients show lymphocytopenia. About 65 to 75% patients show a decrease in eosinophil count and ratio. C-reactive protein, CRP, is also another routinely performed test in patients suffering from an infectious etiology. 55% patients show a significant increase in CRP. Procalcitonin is widely used biomarker to assess the risk of infection and disease progression. Most COVID-19 patients show an increase in the PCT level during the course of the disease. This would suggest that the disease could be associated with a bacterial co-infection and require blood culture or a sputum culture. It is highly important to start antibiotic treatment in such patients. Another reason for an increase in PCT could be an overall deterioration of the patient's general condition, and the patient might progress into shock, developing an inflammatory syndrome known as COVID-associated pneumonitis. This has a rather complex pathophysiology. Overall, if a patient has milder COVID-19 infection, they are generally expected to have a low PCT count. This provides a confirmation of a viral etiology, and an increase in PCT levels must be taken seriously. Ferritin is a key mediator of immune dysregulation, especially under hyperferritinemia, contributing to the cytokine storm. It has been reported that fatal outcomes of COVID-19 are accompanied by a cytokine storm syndrome. Another significant biomarker, such as interleukin-6 or IL-6, is also elevated in cytokine storm. It is very important because of its pleiotropic effects, and circulating IL-6 levels are closely linked to severity of COVID-19. This test should be done in every patient diagnosed with COVID-19. Lactate dehydrogenase or LDH is also another laboratory test that we perform which shows significant elevation in patients suffering from COVID-19. LDH is an intracellular enzyme found in the cells of almost all organ systems, which catalyzes the interconversion of pyruvate and lactate. Severe infections that cause cytokine-mediated tissue damage release LDH as well. LDH is markedly elevated in COVID-19 patients who suffer from extensive lung damage. Studies suggest that there is a high correlation between severity and outcome of COVID-19 patients with an increase in D-dimer. An increase in D-dimer level indicates the activation of coagulation following a fibrinolytic process, demanding for further diagnosis and therapeutic approaches. Many COVID-19 patients thus present with development of ischemic stroke, deep vein thrombosis, and pulmonary embolism. Other investigations such as cardiac enzymes might be required in cases of myocardial infarction, along with an ECG. Routine investigations such as serum electrolytes, serum creatinine, blood urine nitrogen, liver function tests should also be performed according to the clinical judgment. Management of COVID-19 largely depends on the severity grading. Following this technique not only helps us in providing an appropriate management, but also helps us by admitting only those patients to the hospital who require a much more drastic treatment. This in turn prevents overwhelming of the healthcare services without compromising on life. Severity grading is divided into three categories. The least severe patients belonging to the green zone, patients who require hospital admissions belonging to the orange zone, and patients who require intensive care units be classified into the red zone. Patients belonging to the green zone are generally aged less than 55 years, presenting with mild symptoms, having no past history of any comorbidities. On examination, they maintain an oxygen saturation of more than 95% on room air without any oxygen support. On further investigation, their reports are found to be within normal limits. Such patients require home quarantine and treatment, whereas patients classified under the orange zone are generally aged more than 55 years and they do have a past history of some comorbidities such as hypertension, diabetes, COPD, or any autoimmune immunocompromised state. On examination, such patients are tachypneic or are unable to maintain an oxygen saturation of at least 94% on room air. They have abnormal investigations such as ECG, chest x-rays, or any other abnormal routine laboratory blood test such as CBC, serum creatinine, D-dimer, etc. It is advisable for such patients to get a high-resolution CT scan and get admitted to the hospital wards as soon as possible. Patients presenting late to the hospital generally deteriorate and are unable to maintain oxygen saturation of more than 90% despite providing an adequate supplementation of high-flow oxygen. They are classified into red zone. Such patients are hemodynamically unstable. They may present with an abnormal blood test such as elevated cardiac enzymes, raised prothrombin time, raised international normalized ratio, that is INR, D-dimers, or may show acute changes on the ECG, or maybe an abnormal 2D echo. This suggests cardiac involvement as well. A repeat HRCT scan of the chest in such patients shows signs of deterioration. They may deteriorate into septicemia, eventually leading to multi-organ dysfunction syndrome and death. Such patients require an immediate admission to the ICU, urgent NIV support or intubation according to the arterial blood gases and the physician's judgment. Patients under the green zone can be managed at home. They generally require supportive therapy and symptomatic management. Tablet paracetamol can be given in case of fever spike. Dosage would be decided based on the liver function test. Multivitamin therapy, including tablet vitamin C 2 times a day, vitamin D3 up to 60,000 units a week for about 4 weeks, can be also administered. Antibiotics can also be administered in order to prevent bacterial co-infection. Capsule doxycycline, about 100 milligrams, can be given twice a day for about 5 days, and ivermectin once daily for up to 3 days. Cough and expectorant suppressants can also be prescribed in such patients. Green zone patients are generally stable, but a watchful wait is necessary. There might be any chances that this patient might deteriorate further. Patients classified under the orange zone require in-hospital care. Such patients generally require oxygen therapy since they are not capable enough to maintain oxygen saturation of more than 94% on room air. Oxygen can be supplemented via nasal prongs, a plain face mask, a non-rebreathing mask, or in cases where a patient has a past history of COPD, a Venturi mask can also be used. Injection methylprednisolone, about 40 milligrams twice a day, or injection dexamethasone, 6 milligrams once a day, can be given to such patients. Such patients generally tend to have a compromised respiratory system, and corticosteroids is required by them. Several researchers across the world suggest that corticosteroids are beneficial to patients suffering from COVID-19. Antiviral injections such as remdesivir can be given about 200 milligrams bolus dose, followed by 100 milligrams for about 4 to 10 days. or in cases where stability is a little bit maintained, oral favipiravir at 1800 milligrams of bolus dose 2 times on the first day, followed by 800 milligrams 2 times for 7 to 14 days can be given. These antivirals are said to speed up recovery and prevent longer hospital stays. Oral antibiotics like doxycycline can be given for up to 5 days to prevent bacterial co-infection again. In case of deterioration of the patient due to cytokine storm, which can be detected by markedly elevated levels of interleukin-6, ferritin, and LDH, injection tocilizumab 400 milligrams or alzumab 1.2 milligrams per kilograms of body weight can be given slowly for up to 10 hours. These are monoclonal antibodies and they can be helpful in patients suffering from COVID-19. Of course, the families and the relatives need to be explained about the risk factors. In case of a raised D-dimer of more than 2000 nanograms, researchers suggest that there are major complications that tend to occur, such as coagulopathy, leading to ischemic strokes, pulmonary embolism. Subcutaneous low molecular weight heparin, 60 milligrams or 40 milligrams, depending on the dosage of the treating physician, can be administered as a prophylactic agent in order to prevent such complications. Injection vitamin C, vitamin D3 can be administered as well. Plasma therapy can also be considered in such patients. In case of severely deteriorating patients requiring ICU admissions, they are classified generally under the red zone. Such patients fail to maintain oxygen saturation at an optimum level despite supplementation of adequate oxygen. They require non-invasive ventilation or BiPAP support. They may also require intubation if they fail to tolerate BiPAP. Counseling is very important for such patients. Prone positioning of the patient provides more room for the lungs to expand. This can be utilized in COVID-19 patients. High doses of vitamins can be administered. Antivirals and antibiotics should be administered as per orange zone, which is very similar. Monoclonal antibodies administration and plasma therapy can also be considered. A HEPA filter can be used during intubation to reduce aerosolization of the virus, preventing spread to healthcare professionals. Administration of broad-spectrum antibiotics intravenously can be started in order to prevent septicemia due to superadded bacterial infection. Patients recovering from COVID-19 show long-term effects of the virus, the main complication being respiratory failure. Respiratory failure seen in post-COVID patients is generally type 2 in nature, where a decrease in oxygen and increase in carbon dioxide is noted, with a low respiratory drive. Such patients require long-term oxygen or NIV support. They are very significantly similar to a patient suffering from COPD. They can be treated with the nebulization of beta agonist and inhaled corticosteroids. Ipratropium bromide, theophylline, aminophylline can also be used to treat such patients. An HRCT scan of the lungs show that such patients have a resolution of ground glass opacities, which was seen earlier during active viral infection, but they develop fibrosis of the lungs. Oral pirfenidone can be used in order to treat pulmonary fibrosis. It works by reducing the production of growth factors and procollagen 1 and 2. Hence, it is known to have a well-established antifibrotic and anti-inflammatory properties. Another significant complication is coagulopathy. They generally present with an ischemic stroke, deep vein thrombosis, resulting in pulmonary embolism, or in some cases a myocardial infarction. During laboratory testing, D-dimers, cardiac enzymes, and ECG is thus necessary. Such complications should be treated accordingly. COVID-19 has led various countries into a state of lockdown, leading to economic instability, financial crisis, ultimately causing severe mental health effects. Various vaccines are currently being developed by many countries. Most of them are in their final phase of trial. This means that we are not very far away from achieving a definitive treatment. But until that has been achieved, we must try to control the spread of the virus, reduce hospital admission, and protect our healthcare system, ultimately saving more lives. If you enjoyed my short presentation, please share and leave a comment below for any queries. You can also email me at dryash2495@gmail.com. Thank you, take care, and stay safe.